All right, we're back. Cardiovascular drugs, part dos. All right, let's move to the next slide. Oh my gosh, what happened to Chuck? Well, let me tell you what happened to Chuck. It's a couple of years now down the road. He's had this high blood pressure. He's had this high cholesterol problem. Now, this morning, he wakes up. It's 3 o'clock in the morning. His left shoulder is starting to hurt, and it's kind of in his chest. His chest feels tight, and so he gets up and he stumbles out of bed and he takes some aspirin and he goes back to bed, and it just doesn't get any better. In fact, it's starting to get worse. And so he wakes up his wife. She's immediately recognizes it that he's possibly having a heart attack, and they call 911. And whenever they put him in the back of the ambulance, this is what they find. So I'm not asking you to learn EKGs. That's not what you're here to do. But I am going to tell you that this is a sign and symptom of an acute MI. He has ST segment elevation more than 1 to 2 millimeters in each of the, and more than 2 cardiac leads. Therefore, Chuck is having an acute MI. Now, before he gets to us at the hospital, there's a couple different things that our EMS partners are going to be doing for us. They're going to get this initial EKG. They may give him, start an IV on him, give him some nitroglycerin. There's some medicines they want to give to help Chuck to start to feel better as fast as they possibly can. So, now, to be honest with you, because we're healthcare providers and we've been watching Chuck this whole time, we kind of knew that this was a possibility. He had some major cardiovascular risk factors. He had high blood pressure, he had cholesterol issues. We could see this coming from Chuck from a mile away. So here's just a little, brief little synopsis about what a myocardial infarction looks like, the signs and symptoms that we would see. And here's a super helpful little blip that tells you about, if a patient was having an acute MI, these are some of the medication classes that we would think about giving this patient. The biggest thing that we want to talk about is that we want to talk about medications that are going to help to relieve the squeeze that's going on in this heart. Some of these medication classes we've already seen before. Now, I will tell you, in an acute MI, we're going to be grabbing for the nitroglycerin. But if we have this type of an angina that's predictable, we know when it's going to happen based upon exercise or what he's doing, then we can order some of these other medications like beta blockers, calcium channel blockers, or even Renexa that will help to prevent that angina from going on during these predicted times. So here's our drug old-fashioned nitroglycerin. So true story about nitroglycerin. The way that we figured out that it was really good for cardiac patients was that there used to be men who would work in the dynamite mine, TNT, nitrates, right? So what would happen is these people would work in the mines and were exposed to levels of nitroglycerin every single day of their lives. 2 weeks after they would retire, boom, they dropped dead. Why? Because they were no longer getting the benefit, the vasodilating benefits to their coronary arteries that they had been getting for all those years. So nitroglycerin is our primary drug when we talk about someone having acute angina. So nitroglycerin here is our prototype. We typically use this to treat spastic angina. We don't really use this to treat the predictable angina. The calcium channel blockers, the beta blockers, they're usually better at preventing that kind of angina from ever happening. This is, oh my God, I'm having a hard time, I've got this chest pain. This is that type of a medication. This is the kind of medication that we want the patient to keep on them at all times. Sorry, my dog. So the cool thing about nitroglycerin is we have a couple of different ways that we can actually administer this medication. So one way is that it comes in like a little pill. You put it under the patient's tongue, sublingually, there, and you give 1 dose every 5 minutes up to 3 doses. Typically, if the medication isn't effective after 3 doses, they'll have them call 911 and bring them into the hospital. Typically, when the patient gets that little pill under the tongue, it's kind of tingly and it'll make them feel kind of funny. So it's important to kind of understand that. The other thing is too is that we also have spray. So nitroglycerin spray literally looks just like this brown bottle, except it's got a little spray top on it. And they go and they spray, and it's the same as taking 1 pill. We can also give it topically, meaning that we can put it onto a patch. Typically, whenever we give it in the hospital, what we have is we'll have like little papers like this, and we'll put 1 inch of the paste down, and then I fold it in half and I squish it, and then I open it back up and I stick it to the patient. Some people will put it on their chest wall, some people put it on their upper arm. It just really depends on what your preference is. Do not get nitro paste on your skin because it is a medication that likes to give and receive people. So you will get the benefits of nitroglycerin if you get it onto your skin. I remember hearing a story when I was in nursing school about we used to put nitroglycerins in tubes, kind of like toothpaste, and they would leave it at the bedside because every patient got their own tube. Well, one day this lady comes in and husband is just out, like drooling on the pillow, had to be revived. And the woman had an awful headache because she had the cream, had put it on her hands, and had rubbed it all over her husband's back. So very important that we don't leave these things just laying around for people to find. Typically, whenever we give it in the hospital now, it comes in little bitty individual serving sizes of nitroglycerin, but the tubes are still available for at-home use. We also have other oral versions of nitroglycerin. The long-acting version is isosorbide mononitrate. It is an extended-release nitroglycerin. So with this medication, the patient takes it once a day, and they get that slow release all day long of nitroglycerin, so they're constantly being vasodilated. It's good stuff. So with the nitroglycerin pills, I need you to understand they come in a little brown bottle, because they're very similar to this, and they're little bitty tiny things, and they're very prima donna. They want to be kept in their original container. Don't let people take them out. And they want to be kept at a constant 70 to 75 degree temperature. Now, typically our houses are 70 to 75 degrees, but that's not where people put them. Instead, people try to keep them on their person, like in their pockets or whatever. So I'd love for them to keep their nitroglycerin where it's supposed to be. However, I'm a realist, and I show you that most of my patients look like this. That's right, they all look like scary farmers. And where they put their nitroglycerin? Right there in their front pocket, baby. That way I have it if I'm out in the field and I need it. But the problem is that whenever they do that, they keep their nitroglycerin in their pocket. 98.6 degree body, maybe hotter in the summertime, then those nitroglycerin pills may or may not be effective if they're taking them. Okay, I do want my patients to replace their little nitroglycerin bottle once every 3 months. I will tell you that sometimes that in and of itself is a chore or a please, would you just replace it? They're like, but baby, I ain't taking none of it yet. It's been in the brown bottle, it'll be fine. Okay, it needs to be replaced at least once every 3 months to make sure that the preparation of nitroglycerin in that bottle is going to be effective for them. Nitroglycerin IV, it also is very particular about the way that it's stored. It comes in a bottle. We have to use special tubing with it. And with this medication, we tend to titrate the dose, meaning that we're not going to give the same dose to you or to you or to you. We may be giving different doses. Sometimes 3 milligrams is all you need. Sometimes you need 5. It all just depends on the individual's response to the medication. With this medication, it requires constant monitoring by a good nurse. Okay, start the IV, get the medication going on the patient, and then we're going to watch them very closely. And this is also one of those medications that we talk about needing to wean off of gradually. We wouldn't want someone to get nitroglycerin, get nitroglycerin, get nitroglycerin, and then they're all just like, turn it off. And then as soon as you turn it off, everything is going to vasoclamp back down. So want to make sure that we have interventions in place to take care of these patients as we're taking them off their nitroglycerin drips. Here's how you do the nitroglycerin dosage calculation. No, I'm not going to ask you how to do this, but I did want you to at least have seen it at least once. So what do we need to know before we give nitroglycerin? We always want to monitor their blood pressure before and 5 minutes after we're giving any oral doses of nitro. So typically that's what I do. I go to the bedside, do all my checks, take my blood pressure, give that first dose of nitroglycerin, making sure that the blood pressure is greater than 100/60 before I drop the first dose in. And then I'm going to stand there for 5 minutes. And we're going to talk, and we're going to talk about the weather, and we're going to waste an entire 5 minutes with me just sitting there talking to you and doing things in the room. We want to make sure that this patient's blood pressure doesn't drop dangerously low whenever we start to give the nitroglycerin. Warn these patients before you give it to them that nitroglycerin will cause them to have a really good headache. And it's totally fine to give them some Tylenol for the headache even before you give the nitroglycerin. If they're wearing their nitroglycerin, we have the paste that we can put on. We also have little patches of nitroglycerin that they can put on, look like little sticker dots. But what's important is that every day we have at least a 6 to 12 hour window in which we have a nitro-free zone, meaning that the patient has got their patch off or got their disc off so that our body has a chance to get used to not having the nitroglycerin on. So this would be a medication that we would probably start on Chuck right away when he came in. I will say that in these last couple of years of nursing, that we probably don't do as many nitroglycerin drips as I did when I first started in nursing in 2000. The reason being is because we've really gotten more advanced, and we send the patient to our cath lab almost immediately. EMS will transfer that upload or send us that EKG from the field. We identify it as an acute MI. We call the cardiologist. The ER doctor talks to him, and then that patient just says, "Hi, bye," and boom, they go straight to cardiac cath lab, because that's really what this patient needs in order to be able to reconnect their perfusion in their heart. But let's say that Chuck was in a place that he didn't have access to a cardiac cath lab. And so because of that, we have other options that we can do, especially if Chuck was to live in our outlying surrounding counties. It's really hard to get patients here to the Brazos Valley during bad weather or during hurricanes or tornadoes or flooding. Sometimes in those counties, there's not even trucks. So we may identify that someone's having an MI, but we can't get them to our facility fast enough. So because of that, we sometimes will use different types of medicines to thin their bloods. The different types of medicines to thin their bloods are called thrombolytics, anticoagulants, or antiplatelets. In an emergent situation, we will use a thrombolytic. And let's talk a little bit about those now. So thrombolytics are scary, but they work scary well too. Their main function is that they actually will find a clot and then take that clot, and it's a lot like Pac-Man, goes and will eat the clot away. These medications are like streptokinase, activase. They work really well to help to bust up clots. However, there is very strict criteria about who can and cannot get a thrombolytic. Let's say this morning that Chuck had a nasty nosebleed, okay, for whatever reason. It had clotted off and no big deal. When we give Chuck a thrombolytic, anything that has recently been injured will break open and start bleeding again. So we can actually put the patient at more risk by giving a thrombolytic because of the mechanism of action of the medication. We know that when we give a thrombolytic, we really like to give it within 20 minutes to 12 hours after the onset of symptoms. We'll sometimes even give thrombolytics to patients who have had strokes so that we can try to get them back to the most normal life as possible. Our goal is that from the time that they hit our emergency department to the time that the thrombolytic is actually administered is a total of 30 minutes, which can be really, really pushing it whenever we talk about some of the great things or many things that happens in the life of an ER patient. These are all the contraindications that come along with having thrombolytics. A lot of our hospitals have gone to using checklist systems in order to be able to quickly make sure that we're assessing everything that we need to be assessing so that the patient doesn't have an adverse reaction. When we get ready to give a thrombolytic, it is nursing staff that's giving it. Okay, no, I mean, guys, it's crazy. It's like, wait, you're going to give me a medication that's going to burst up a clot and I'm going to administer it? Well, I think you should do it, doctor. No, it is our responsibility as nurses to administer the thrombolytics. So here's kind of like a brief little okay, checking my labs. Number 2, do I have 2 IVs? 2 IVs. Okay, I got 2 IVs. Do I need a Foley catheter? Because if I need a Foley catheter, I need to put it in now because we can't put it in for the next 24 to 72 hours because if we do, they're going to start bleeding. So everything becomes this very much a very well thought out process for a patient who's going to be who you will be administering thrombolytics to. Anticoagulants. So let's say that Chuck comes in and he's had this cardiac event and we got him to the cardiac cath lab and maybe they put some stents in or something like that. Typically, those patients, after they have a cardiac event, need to be on anticoagulant therapy. They don't really dissolve the clots, but what their job is to keep everything kind of slippery and slidey so that everything basically just kind of goes through the arterioles and through the veins without any hiccups, okay? And typically, it is one of our core measures meaning that we make sure that this happens for this patient before they're discharged home from the hospital. We have a couple of different types of anticoagulants. We're going to talk about a couple of them. Heparin is probably the most known and the most notorious on this list as being the one that we give IV in an emergency situation. Low molecular weight heparins, you're going to give those too, and then warfarin, we'll talk about it because it tends to be a nursing school favorite. So heparin's main job, whenever we think about anticoagulants, we have to think back to anatomy and physiology. We have to think back to that frickin' coagulation cascade. Remember all these gates and locks, and like you can partially open a gate or partially close a gate or completely close a gate, and that's going to help to figure out whether or not you're going to bleed or not. That's what heparin does, is it partially helps to open up some of the gates so that the patient has a decreased chance of having another clot form because everything's going to be kind of slipping and sliding. The only problem with heparin is that it is digested in the stomach, so there's no possible way, like first pass effect, boom, the whole medicine's gone. So this one can only be given IV or sub-Q. It is a naturally occurring drug. We do find it in nature. We monitor the partial the PTT, the partial thromboplastin time. Sorry, my words. We do have an antidote for it. It's called protanamine sulfate. So in case of hemorrhage or in case of an overdose, you can give protanamine sulfate to help to reverse heparin. Typically what happens is like the therapeutic effectiveness of heparin, right? The minimum concentration, it comes up here. We get to a minimum concentration effective dose, a minimum effective dose very quickly. But as soon as we stop taking it, it drops off really quick. It doesn't have a very long half-life. So in order to get this patient off of heparin, because they can't take IV or sub-Q medicines the rest of their lives, then what we'll do is we'll add one of our oral agents at the same time that we're giving the heparin, so that way it has time to build up to its minimum effective concentration, and then we can take heparin off, and now we have a anticoagulant effect with our oral preparations. So heparin questions will make you shake and shudder. I do want to show you just briefly how you would go about doing this. Again, I'm probably not going to ask you to do it, but I want you to understand that there is a process for figuring out how to do a dosage calculation with heparin. Our other famous anticoagulant that we'll see a lot of in the hospital and facilities is enoxaparin. With this medication, we give it sub-Q. We can also give it IV in emergency situations, and Chuck would have probably been a pretty good candidate to give it emergently. We do need to monitor our lab values, our INR, our PT, and our platelet counts to make sure that these are all staying within their normal limits. With this patient medicine, what we do is you go up to the patient and you pinch their love handles. That's right. You find a little chunk of fat right there on the side of the belly where most people have it. I have a lot of it. And then that's where you're going to give the medication. It's really important that when we give this medication, there is something in there. It's called a nitrogen bubble. The bubble, we don't want to get rid of the bubble in a enoxaparin Lovenox injection. That bubble serves as like a cap so that the medication doesn't come squirting back out. So, typically when you give an IV medication, you want the point up and you want the air to come to the top and you want to squeeze it and pop the air out. Not in a Lovenox injection. In a Lovenox injection, you want to keep the air bubble at the top of the syringe, and when you go to give it, you want the air bubble back here at the back. So when you give the medication, the air bubble comes down, expands under the skin, and essentially traps the Lovenox inside the skin. That's the point of the nitrogen bubble. But Ms. Hardy, you said we could also give this IV. Yes, I did. And here's what I'll tell you about that. When you give it IV, you don't give the nitrogen bubble, okay? Nitrogen bubble bad in the IV. Nitrogen bubble good in the sub-Q. Pradaxa is another one of our medications. What's great about this one is that it makes you instantaneously therapeutic. We're always trying to strive for therapeutic levels on these medications because we don't want them to clot anymore. So the good news is this medication makes you instantly therapeutic. However, it is very expensive. We also have some other drugs out there, Eliquis being one of them you'll see quite frequently in this community. Coumadin. Coumadin is a nursing school favorite, guys. It's always here. It's always here for the class reunion. We can't get away from Coumadin, people, okay? Coumadin's cheap. That's the great thing about Coumadin. Some of the other medications, Eliquis being one of them, they have come down in price, which is nice. So we may start to see a market shift more towards those. They're definitely easier to manage. Patients on Coumadin, you have to like do a daily lab value, and then you got to get them, find them where they're therapeutic. You want to make sure that their INR lab level is at least a 2.0 or greater, and then they have to be careful with their diet. I mean, guys, it's just kind of a pain in the butt. And then once they've taken the Coumadin, then you actually have to have them come back into the office and have their blood work redrawn like monthly. Okay, so if a patient whose compliance is really, this is probably not the drug for them. However, they could probably afford this drug. It's cheap, very cheap. The antidote for Coumadin, you absolutely have to know this. The antidote for Coumadin is vitamin K. So here's the problem. Because the antidote for Coumadin is vitamin K, foods that are rich in vitamin K can deactivate it. So we have to talk to our patients about what they are eating. I will tell you that it would take an extraordinary amount of mayonnaise to make a difference, but it really doesn't take that much green leafy vegetables, the spinach, the chards, the kale, and even broccoli to make a huge difference in their INRs and how their Coumadin is responding to them. The big thing that we need to tell patients is that everything in moderation. Like, I know when I was growing up, my mama would make a big pot of greens and we would eat them like once a week or once a month or something crazy. But if we're not going to have that consistently, then it can really affect the labs. Okay, so just to be thinking about, they need to be consistent with what they're eating in order for the Coumadin to work most effectively. Here's our pretty little slide all about Coumadin. Again, pretty funny. I love this one. It's like Mr. Coumadin and Kay, they're together. So cute. Here's another little slide. A lot of time with this, I'm telling you people, this is a nursing school favorite. Coumadin and heparin. People just love to irritate y'all about heparin and Coumadin. I'm like, y'all need to find something else to pick on. Coumadin, we look at prothrombin, and it's vitamin K is its antidote. With heparin, we look at the PTT. And again, a helpful way here to help you to remember which labs go with which drug. Again, nursing school favorite. You're going to hear a question about Coumadin and heparin. I promise. I promise. I swear. Antiplatelet drugs. So we already talked about the most famous antiplatelet drug earlier. We've talked about aspirin. Aspirin comes back again, and again, it's another one of those great things. It has non-steroidal anti-inflammatory properties. We also like to use aspirin because of its antiplatelet property. With these medications, we want to make sure that we are monitoring the platelet levels because these medications can monkey with them, and the next thing you know, patient's got a horrible platelet level and they're bleeding everywhere. Here's our list of antiplatelets that we're currently seeing on the market. Aspirin, like I said, the most popular by far. Oh, excuse me. Ooh, the most popular by far. However, you're going to see a lot of clopidogrel out there, people. I'm like, you're on clopidogrel, and you're on clopidogrel, and you're on clopidogrel. And then, of course, Eliquis as well. So we already kind of know this stuff because we're smart and we've already read about aspirin, but I have to put it up here because I got a feeling that if we were going to put Chuck on something, aspirin's cheap, people. It's cheap. Side effects of aspirin, again, we've kind of already gone over these. Here's clopidogrel. Love clopidogrel. We see so much clopidogrel in our community. We're using it a lot. One of the crazy things about clopidogrel is that it lasts for 7 days after you discontinue it. So I'll tell you that typically patients, I'm sorry, I'll stop yawning. Typically patients who are taking clopidogrel need to watch out for increased bleeding effects. And we need to make sure that these patients are at least 7 days off their medication before we go in and do any kind of elective procedure. And that includes dental work. Again, hemorrhage, decreased platelet count. We want to make sure that if we're giving them with other things, that we're making sure that we're not getting this add-on effect. Like if they're taking Plavix and also taking aspirin, that may not be the best therapy because we're going to get an increased amount of antiplatelet effect. With these patients, also always have to watch for signs of active bleeding. See, active bleeding. Things like black tarry stools. Whenever they shave, do they seem like they bleed forever? We want to make sure that if they fall, like if they were to fall and they were out and their anticoagulants were out of whack and it was really, really high, it could cause a lot of blood to rush to the area and have a lot of swelling. We had a guy come to the hospital, it's been a couple of years ago now, and he was getting Lovenox injections because he had a blood clot in his, I think it was in his lung, or maybe he had a stent put in. I can't remember why. But so this patient, we were giving him Lovenox, then we put him on Coumadin, and we sent him home. And this big burly man comes back in like 3 days later, and he looked like he had been beaten with a 2x4. He was blue, black and blue, from the top of his head all the way down his back and all the way down to his lower leg. And I asked him, like, what did you do? He said, girl, I don't know what happened. Well, when we got his lab values back in, we could tell what happened. His Coumadin level was his INR that should be between 2 and 3 was at 6. And then they had also put him on an antiplatelet medication, and his platelet count was down to like 50,000. Way over medicated. And I said, so what were you doing when this started? He goes, I woke up in the middle of the night and I had a cough. And I coughed and I coughed and I coughed. And then all of a sudden my back stung really bad. And then it just bruised and literally had a spontaneous bleed right underneath the skin, top of his head, all the way down his side, all the way to the back of his knee. It was incredible. I never want to see that again in my life. Again, we had that man all messed up on his drugs. All right, guys, so that's all that Chuck would be going through right now. So the nitroglycerin for the chest pain, sublingual PO, get him to cath lab as fast as we could. If we didn't have cath lab available, we'd be thinking about thrombolytics. Let's say that he did go to cath lab and they did something fun in there. Then we need to be thinking about our anticoagulation therapy or antiplatelets to keep him healthy for the interventions that we've done for him. But I've got more to tell you about Chuck in just a minute.